afternoon. Let's try that again. Good afternoon. Welcome. My name is Katrina Kiefer. I'm the Chief Executive Officer of Augusta University Health System and Executive Vice President of Health Affairs for Augusta University. It's my pleasure to welcome you here today to the town hall focused on coronavirus to help you to stay informed and keep yourself and our patients safe as this outbreak worldwide continues. After a few additional opening remarks, we will turn this over to our clinicians and then have time for questions and answers. I not only welcome those of you who are here live in the auditorium, but those that are joining us via live stream. Also note that this session will be recorded and will be made available online as a part of our website resources. For those of you during the question and answer session who choose to ask a question of one of our panelists, I invite you in the auditorium to please use the microphones so that you can be heard by all. And for those of you participating via live stream, if you have questions or answers, you may submit those to cpar@augusta.edu or on Twitter as outlined on the slide here. So without further ado, I'd like to introduce our provost, Dr. Gretchen Coughlin.
Thank you so much, Ms. Kiefer. I'll be brief as well. Thank you so much for joining us. I think you, like we, are committed to making this environment, our academic and professional and clinical home, as safe as possible for all of us as well as for all those we serve. We are fortunate to be affiliated with an academic health center, the hospital, the medical center. You're going to hear from some experts that really will help us as a university, because that's more of what I represent, in ways that many of the non-health sciences, non-professional academic health centers can, those universities. So we want to take full advantage of that. However, we are also very cognizant of the fact that it is not all about that clinical aspect. We have other things that we must attend to as a university, including instructional continuity for our students, the safety and the teleworking perhaps of our faculty and staff, all of the things that go into ensuring that our university continues to function in the most efficient, effective, but also safest way possible. So we're committed to that as well. It's my pleasure now to introduce to you, as always, our president and leader, Dr. Brooks Keel.
Thank you very much, and it is a pleasure to be with you this morning, and thank you so much for taking the opportunity to spend a little time with us here today. Let me just sort of give you some brief comments as well, and then as the provost and Katrina said, we're going to turn things over to the real experts who can provide you with a situational update on where we are and answer the questions you may have. For those of you who have heard me speak, have heard me say over and over again, I hope that you or know what I'm about to say, but you never get tired of it, and that at Augusta University, our first and only priority is our patients and our students. But we know we can't provide the world-class education for our students, and we can't provide the state-of-the-art clinical care for our patients without outstanding faculty and staff. And so therefore, the safety of our patients and our students and of the faculty and staff who teach and care for them are obviously our main concern. They've always been our main concern. They're our main concern today, and they will be our main concern moving forward. And that's one of the main reasons we wanted to hold these town halls. We're going to be holding two town halls, one here today and one on the Somerville campus on Friday, and to do a couple of things. One is to provide opportunities for Augusta University and the health system community to hear directly from its leadership about our coronavirus COVID-19 preparations, and to allow you to ask and have any questions that you have answered to the best of our ability. As I mentioned, two such town halls. They are being live streamed, as you've heard, so allow our interested faculty, staff, and our students, and our parents of our students who can't be here today to also attend virtually so that they can hear directly from leadership about what we're doing here. We want to provide you all with some assurances. And let me do that now. First, as of this morning, there are no confirmed cases of COVID-19 in the Augusta area. And I'm looking at our experts who will confirm that for us, and they're shaking their head yes. Second, as we have as part of our faculty, and the provost has already mentioned this, top infectious disease and infectious control experts right here at MCG and at AU Health. And again, as the provost has mentioned, don't forget that we're the state's only public academic medical center. Something that's an integral part of Augusta University is the hospital, the health system. And it is one of the only 2 academic medical centers in the entire state of Georgia, and is Georgia's only public academic medical center. We need to take a great deal of pride in that, but perhaps more importantly, especially in times like today, we need to take a great deal of comfort in that, to know that we don't have to go out in search of experts. They're all here right among us. And I don't know about you, but that gives me a great deal of comfort. And lastly, we wanted to tell you that we have numerous preparation and response efforts already underway. And let me give you just a couple of examples of that. In February, I created the President's COVID-19 Task Force of administrators and experts across the university and the health system who are meeting regularly, even as we speak, to keep us all informed on our preparedness. I and my senior staff receive daily briefings on the situation awareness and on our response readiness. We are in constant, daily, and sometimes hourly, if not minute, contact with the Centers for Disease Control, the Georgia Health Department, and the University System of Georgia, who will help coordinate our efforts and who will help us in the proper decision-making going forward. We have plans in place to ensure our educational, clinical, and business continuity under any foreseeable circumstances. It's important to know also that this is a very fluid, dynamic, and very changing situation. We're really just beginning to understand what this disease is, what its impact is going to be, and how to respond to it. And you're going to be hearing more about that in just a minute. Therefore, it is important, and we want you to all stay informed as well on a regular basis. And we encourage you to do this by visiting the Augusta University website and look at the very top banner. There's a button there to click that says the COVID-19 resources. That is the go-to place for all information that is related to COVID-19. That is that we change that on a regular basis. If you don't hear an email or see a response from me or the provost or from Katrina or any of our leadership, go to that site and it is updated on a regular basis. And if nothing else, you can see that nothing has changed since the last time you looked at it, and that should give you some comfort as well. It also on that website, when you click on that, has links to other very important sites or information such as the CDC, World Health Organization, University System of Georgia, and other sites to provide you with information. We want you to be informed and prepared. Lastly, it's important that you all know that we are prepared. Let me repeat that. We are prepared, both as a university and a health system, to continue our mission of providing outstanding educational opportunities for our students and outstanding clinical care for our patients. We will continue to be over-prepared so that none of us has to overreact. Okay, I'm going to repeat that to you. We're all going to continue to be over-prepared so that none of us has to overreact. The best takeaway I think I can give you and hope that you will take away from this entire town hall is quite simple. Stay calm and wash your hands. That's about the best advice I think any of us can give you. But as I said, we have experts here that are going to give you the whole story on where we are with COVID-19 and a lot more about what our preparedness has been to date. And it's now my pleasure to turn things over to two of the experts that I mentioned just a few minutes ago, Dr. Philip Kuhl and Dr. Jose Vasquez.
Thank you, Dr. Keel. It is a pleasure to be here, and thank you to everyone for attending today. We, I think, are going to be able to provide you a pretty good overview of information. Some of it will be new. Some of it, hopefully, will be old information to you. I am the Vice President and Chief Medical Officer for the Augusta University Health System and Associate Dean of Clinical Affairs for the Medical College of Georgia and a Professor of Emergency Medicine. The information about the coronavirus, I think, is kind of important to start with the basics because there is a great deal of misinformation that's out there, and I think it's important to make sure that we cover some of the basics. So first of all, coronavirus is actually referring to a group of common viruses that typically affect the respiratory system of mammals, including humans. They're associated with a common cold, pneumonia, and acute respiratory syndrome, but the virus is actually, or the group of viruses, the coronaviruses, are responsible for about 15 to 30% of the common colds. Coronaviruses are named because of their spike-like projections from the surface of the virus. They were first isolated in 1930 from an infected bird, and the first human coronaviruses were identified in the 1960s. Now, there are 7 types of coronaviruses known to infect humans. Unfortunately, humans can be repeatedly infected even with the same strain of the virus because the antibodies are not long-lasting. And antibodies from one strain of the virus are not effective against other strains. Now, there are 3 types of coronaviruses that are known to cause significant human impact. That is SARS coronavirus 1, or SARS-CoV, that was an outbreak in China from 2002 to 2004. And you see the number of cases and the number of the mortality from that. Middle Eastern respiratory coronavirus, which was 2012 and is ongoing but does not have significant ongoing spread right now. And then the current outbreak of what is now called SARS-CoV-2, or the lung disease that's caused from that is COVID-19. Now, transmission for COVID-19 or SARS coronavirus 2 is person to person and happens through close contact. Close contact is defined as within 3 to 6 feet of an infected person for greater than 1 to 2 minutes. The droplet spread of this is similar to that of influenza and other respiratory pathogens. And generally speaking, the majority of infections occur from being in close contact, and then someone coughs or sneezes, expels droplets, and those are inhaled by the person being infected. There is some concern about survivability on surfaces, but that is unclear. There's some data to suggest that may be hours, and some data to suggest that could be days. We do know, however, that it is easily killed. So this has an envelope, and there's good evidence to suggest that products that we know that are effective against SARS-CoV-1 are also effective against SARS-CoV-2 or COVID-19. It has a 2 to 14-day incubation period where the person may develop fever, cough, and shortness of breath. It's important to understand that the best evidence is that about 80% of patients have minimal symptoms. So they essentially have a cold, maybe a little bit of a low-grade fever, and that's it. And that's in 80% of cases. About 15% of cases develop severe illness and may require hospitalization. And about 5% of patients may become critically ill with about a 2% mortality. Now, I say a 2% mortality, but that is without knowing what the actual denominator data is. There is really good evidence to suggest that the mortality on this may be much lower because in China, where most of the numbers are coming from, for example, if people have minimal illness, they may never get diagnosed, they may never get tested, and therefore they had a minimal course and don't end up in the numbers. So that artificially elevates the mortality for this particular disease. Now, the current state as of 9/13 this morning, 115,855 cases worldwide, about 4,087 deaths. One thing that I think is worth noting on this slide is that if you look at this yellow line on this graph, those are the numbers just in mainland China, and you'll notice that that has leveled off significantly. China is now adding cases at a very slow rate compared to what was happening previously. There's a couple of different ways of interpreting that, but certainly whether it is because they're getting better infection control and better identification of cases early, or whether it's quarantine and isolation that is controlling those, or because a large number of people have already had their course of the illness and are now immune to it for a short period of time. In the United States, as of 9/13 this morning, we had 756 cases confirmed to date. 17 of those are in Georgia that are confirmed cases, but none locally. We have had about 26 deaths in the United States, and currently we have a wide geographic distribution. So there's a couple different ways to interpret that. One of the things that may be happening here is that as we test more for this disease entity, we find it more often. And it may be a new awareness of an existing problem rather than a rapid development of new cases. And we just don't know which that is yet, and have to kind of interpret it both ways and prepare for both. Now, all of these numbers look scary. You know, when you see all the red dots on the map, and especially when if you've seen any of these maps where it consumes the whole country, it all kind of looks really scary. And one might think that, you know, like in Game of Thrones, the White Walkers are coming, and brace yourself because winter is coming. But that really should not be the case. The reality is that when you put these numbers in perspective, this pales in comparison to the flu. So worldwide, about 250,000 to 500,000 people die every year from the flu. In the United States alone, it is estimated that we have anywhere from 9.3 million cases to 45 million cases of the flu. We have hospitalizations ranging from 140,000 to 810,000 cases per year, and from 12,000 to upwards of 61,000 deaths from influenza in the United States every year. So when you look at those numbers, as scary as they may seem, they really do pale in comparison. And essentially, we could think about this as just a really bad flu season. Now, when you think of it that way, what do we do to control the flu? Well, we have some different methods that we use to control the flu, and one of those is to reduce exposure through good hand hygiene and through using hand sanitizer and good cough and sneeze etiquette. And the other is to vaccinate high-risk populations. And unfortunately, one of those is not available to us right now, and that is the option of vaccinating. So there's currently no vaccine. It has been fast-tracked for development, and it's currently in animal trials. We're estimating a timeline of anywhere from 6 to 18 months. 6 months would be really aggressive and optimistic, but certainly possible, and they've been moving very rapidly on the development of a vaccine. So if a vaccine option is not available to us, what can we do to help spread the control COVID-19 and the novel coronavirus? Well, we use different techniques, and that being infection control methods, social distancing, and quarantine and isolation. So simple infection control methods, good cough and sneeze etiquette, washing your hands, using hand sanitizer to reduce the spread of, or potential spread of this virus. Social distancing is basically reducing exposure in community transmission when community transmission is widespread. So if we start to see widespread transmission within the community, then we might institute measures like this as social distancing. And that would include, for example, teleworking, remote classrooms, and most importantly, when people are ill, whether it's from this disease or any other infection, it's important to stay home to prevent the potential for spread to at-risk individuals. Quarantine is eliminating contact with other people by persons who are well but may be exposed to COVID-19. So, for example, a person that has had contact with a confirmed case would be asked to quarantine at home for 14 days and monitor for symptoms to see if they have developed the disease. That's to reduce any potential that this person might become ill and be out in the public and potentially infect other people before it becomes apparent to them that they are ill. So that is quarantine. That is taking a person who is well but exposed and essentially eliminating contact with other people to reduce the potential for spread. And then isolation. Isolation is used for someone who is ill and is either suspected or confirmed to have had COVID-19, and essentially they remain at home or in a hotel room or in a dorm or designated location for people to reduce the potential for spreading either the disease that they have or if it's COVID-19, to eliminate that. So think of this as, if you're ill, you go in isolation. If you're well but exposed, you go into quarantine, and that's a way to separate those two out. Now, that sounds terrible, again, but the reality is that may just mean that it's Netflix and chill, right? So it may be that you just binge watch Netflix and you stay at home for a couple of weeks. It doesn't mean you can't go outside. It just means that you're not going out in public. Now, persons under investigation, the criteria for this is developing, and that is that as we begin to see more geographic spread of this disease in the United States, meaning community spread within the United States, that the travel history component of this will become less important. And really, it will become an issue of identifying people that are at risk. We have the advantage that we're coming off of flu season. Flu is starting to diminish within our community, and that's a big advantage for us. And basically, when we see patients that have fever and signs and symptoms of lower respiratory illness, we will probably start focusing on that as being the risk for COVID-19 and make sure that we're taking appropriate precautions to reduce the spread or contact with that patient to protect our staff as well as our other patients. So what are we doing? As Dr. Keel mentioned, we formed the AU Health System Task Force as well as the Augusta University Task Force for COVID-19. Our CPAR office, which is Critical Event Preparedness and Response, is working in close coordination with local, state, and federal officials. We're trying to make sure that we keep everyone informed by conducting venues like this. We do have a lot of efforts underway, and there are teams working on a variety of different issues, including making sure that we're educating properly, that we have the appropriate PPE, that we have the appropriate stockpiles of PPE, and that we have the proper processes and procedures in place to deal with any cases that might occur in the local area. We're doing these town halls to make sure that we give everybody the opportunity to ask any questions that they may have. And then Dr. Vasquez is going to be doing a grand rounds on COVID-19 coming up later this month. The simple message, as Dr. Keel mentioned, is keep calm and wash your hands. So we do want to be prepared. We want to make sure that we're prepared for any eventuality that may occur and that our health system is ready to take care of COVID-19 patients. It really is just a matter of when we have our local case, our first local case, and how many cases we have locally, and making sure we respond appropriately to those. And again, if you think of this like the flu, this is going to be about 3 to 6 months of a really bad flu season is a way of looking at it. It may tax the system, but we're preparing for it to tax the system, and we'll be ready for that. And with that, I'm going to turn it over to Dr. Joe Vasquez. Dr. Vasquez is the Chief of Infectious Disease and a Professor of Medicine at the Medical College of Georgia at Augusta University. Dr. Vasquez?
Thank you. Thank you. That's right. There is no more shaking hands. You may fist bump, elbow bump, bow. The newest one is actually the foot bump. Whatever it is, actually we should be doing it every year, okay? It's not only for coronavirus, but for influenza, as you notice. So no more shaking hands. I'm sure everybody will understand why we're not shaking hands with everybody. So I'd like to give you a little bit of an update as well. Some of it may be a little repetitious, but coming from a different angle, but I'm just going to show you something that I actually pulled up many, many years ago. I was actually involved with the first SARS outbreak. I was in Michigan at that point in time. The big outbreak was actually in Ontario. So what do I have to do? Hit that. All right, so if you read Time Magazine for your medical literature, here's what Time Magazine said in 1966. All experts agree that by the year 2000, viral and bacterial diseases will have been eradicated. So what are we doing here? You know? Doesn't say anything about fungi or parasites, but certainly all viruses and bacteria. So it's important to note how it's an amazing world and how it actually changes. So this is what we saw back in 2002, Newsweek magazine, SARS, what you need to know, the new age of epidemics. We got through SARS, we're getting through COVID-19, really, and it's important to note, I think the first part of that slide, which says, keep calm and wash your hands. Keep calm, and pretty much here at Augusta University, in Augusta really, we're protecting you. We have your back, we have you covered. We understand what's going on. I've been doing this for 30 years, so we definitely will make sure that you are protected and we do the best possible for not only the students, but for the patients and anybody in Augusta. So this is an electron micrograph of what is a coronavirus, and I guess it doesn't work. The coronavirus, the reason it's corona is because you're looking at that little outer area. It looks like a crown, or corona in Spanish. Those spikes are actually the key that attaches itself. Those spikes attach themselves to the lower respiratory tract. That's why this disease produces much more pneumonia than it does upper respiratory tract symptoms. Those spikes have a tendency to attach themselves to the lower respiratory tract all the way from the bronchi down into the alveoli. So this is a classic electron micrograph, a beautiful picture, if you want to think of a beautiful virus, actually, if you will, but it is a nice picture of a coronavirus. So as Dr. Kuhl said, it is a newly described, it's an RNA virus instead of a DNA virus that causes these respiratory infections. Initially, although we were told about it at the end of December, January, by looking at the literature now, it looks like it was brewing back in November of 2019. It just took them a couple of months to figure out what the heck it was and what it produced at that point in time, because if you recall back to December, January, we thought everybody was eating bats, and that's why they were getting that. Well, it turns out it wasn't that. So it is linked with, and the DNA is linked with bat genetics and sequences, and also with snake sequences. But nonetheless, we think that's probably where it started back in November, which is really the middle of respiratory tract infection season, right? So thus the importance and the differentiation of flu. So how contagious is the coronavirus? We usually in epidemiology use what's called an R-naught. And R-naught is how many folks can you infect, can one individual infect? And what we see here is top of the list is measles. So I guess my take-home message here for the anti-vaccine crowd is vaccinate everybody against all these infections. So especially measles, so you can see how quickly one individual can actually infect 12 to 18 people. So you can imagine what one individual can do and how they vaccinate. Smallpox is another one, polio, mumps, HIV, AIDS, 2 to 5. SARS-CoV-1, the first one, was at about 2 to 5. This second one is somewhere about 1.4 to 2.5, although it's speculation at this point in time because we don't have the data. And the one that we all feared, which was Ebola, about the same, about 1.5 to 2.5. So one individual can infect 1.5 to 2.5 people, so 1 to 2 people. So that's how contagious, and that's the contagiousness of this type of coronavirus. Incubation period, I think Dr. Kuhl. The important part to this is the exposure to virus right away. The key to a lot of the community, probably the community setting, is the fact that 1 to 2% of individuals, probably more in kids, are asymptomatic. And if you're asymptomatic, you're in school, you're at work, wherever you are, and you're passing that virus along to individuals. And that becomes really important. We don't have the data here in the United States because we haven't done enough testing. But once we learn, our rates are probably going to be about the same thing. So 1 to 2% of the population may actually not be infected, but colonized or low-grade infection with the coronavirus and have no symptoms whatsoever. As Dr. Kuhl said, about 80% will have a low-grade respiratory tract infection, a cold, where you could actually go to work, which is what you're not supposed to do. So the other part of this is, if you have no idea how many people have actually sent home in the last 2 weeks because they are stalwart, they're stubborn, they want to come, they want to do their job, they're needed at work, they're not needed at work because one person will infect 2 to 3 people. So staying at home with a low-grade temperature and a flu or cold is really important in this day and age. And then you can see the incubation period. So we think it's somewhere in that range of 2 to maybe 14 days. The spreading is the key. It's via respiratory tract. Manifestations, the two classic manifestations that we always ask everybody is, do you have a fever? Even if it's a documented fever at home, and usually a lower respiratory tract symptom, a cough, chest pain, sputum production on occasion, breathing difficulties. After that, it could actually be anything from nausea, vomiting, diarrhea, abdominal pain, and cramps, but that's really uncommon. The pneumonia becomes severe in about 10 to 15% of individuals. Some of these patients could actually end up in the ICU in kidney failure. But really the key and the bulk of most of this is going to be respiratory tract, lower respiratory tract with a fever. Sore throat and a cough can happen to anybody. And if you look at those manifestations, they're really not much different than other manifestations that we see with the respiratory tract. So this is kind of an interesting figure here. What we're looking at here is the fatality rate across all the different ages, and my pointer's not working, but if you look at down to the right hand on the bottom, those are individuals that are 80 years or above, where the mortality rate is about 15%. Those are the hardest hit. So any patient that's 80 years or above, mortality rate is about 15%. Drop down to the 70 to 79 year, you can see it actually is almost half, about 8%. Go up to the top, up to the left-hand side there is something that we've been talking about. For some reason in kids below the age of 20, the mortality rate is about 1%. So it doesn't seem to attack very aggressively kids from zero, basically neonates, all the way up to the age of 19. And then you can see how at even 20, 30, and 40, it's in the 0.2 to 0.4%. Influenza's mortality rate on an average is about 0.5. So it's a lot less than influenza until you get up to the age of 50 or above. Now, where else we have seen the high morbidity and mortality in the ICU is patients that have underlying comorbidities or underlying diseases, underlying lung disease, liver disease, kidney disease, so patients on dialysis, stem cell transplant, solid organ transplant, so immune compromised patients. Those patients really, we have to be careful because those patients have rates of mortality much closer to the older adult in the 60 to 80 year range. So if you know somebody, family member, relative, you probably should be very careful with the with the exposure. The diagnosis, we don't have any good one locally at this point in time, but it's important. We still are in respiratory tract infection, and the first thing we do with anybody coming in with what's called the PUI, or the person under investigation, is ruling out commonly known respiratory infections. Influenza, we're still seeing quite a bit. We see adenovirus, respiratory syncytial virus, human metapneumovirus, chlamydophila, and mycoplasma. So 2 bacterial infections we still see during this type of season. So all those things have to be ruled out before we say, okay, this patient may actually have coronavirus. How do we do it? It's not a blood test. It's actually a nasopharyngeal swab. And I want to point this out. It's important to note how the swab is done is very important. This is not a swab of your anterior nose. This is actually a swab of the posterior part of your throat and your nose, which means if you do it correctly, you're going to cry, okay? Or you're going to yell, or you're going to gag, because we actually need to pick up cells. If we don't pick up cells on the swab, we can't do the PCR test in that setting. So it is not an easy procedure. If you've ever had a nasopharyngeal swab, it feels like it's going right into the back of the brain, okay? So it's what it felt like to me when I got it. So recognize, if it tickled your brainstem, we got it, okay? That was a good one. So that was a good specimen that we got. If it did not, and you had no symptoms, no crying or anything, it was not a good specimen. Why is that important? Well, it does us no good to collect poor specimens, right? If we collect poor specimens, we're gonna have a bunch of negatives. We don't even know which patient, so because it's not a blood test. And then what we'll do is we'll run the PCR assay, which hopefully once we get it locally should be 2 to 4 hours. The testing is now being sent to the state health department. That takes about a day, depending on the time of the year. So the big problem again is making sure we don't swab the anterior part of the nose. I think, as an example, I was going to bring Dr. Cool up here and try it on him, but, or President Keel maybe would volunteer for that, but just in case anybody's, but it's significant. So we don't have any point of care testing. In the future, I think we'll have antibodies, so we will be able to do IgM and IgG. That's nowhere near what we used to do. Finally, treatment, as I mentioned before, as Dr. Cool mentioned, vaccines are probably at best 6 months to 12 to 18 months out. They're just getting started. Remdesivir is the drug that's being evaluated. Initially had been studied for the SARS and for Ebola, being looked at now. I think one of the treatments, hopefully, that we may have is what I call the summer burnout, which is when we lose a lot of the respiratory viruses, right? And it gets warmer, people are out, there's actually social distancing because you're in parks and you're out there instead of everybody cooped up in classrooms, everybody cooped up in houses. So hopefully it'll start to dissipate. If I recall, the last SARS, the last cases were in June and July. So hopefully by the middle of the summer, maybe we'll have some of that. Finally, how to avoid? Wash your hands frequently. Yes, there is no antiseptic left, but there's a lot of soap left at Publix and Kroger, okay? And actually, soap is just as good as the antiseptic, except you can't take it with you. It works just as well. It's a very susceptible virus because it's got this fat layer, and the fat layer is broken down by soap. So if you don't have the alcohol-based antiseptic, washing your hands with soap and water, 20 seconds. You can count, you can sing, whatever you want to do that takes up 20 seconds, but go ahead and do that. No handshaking, as I mentioned before. Etiquette as far as sneezing and coughing in your crook, in a napkin somewhere else besides somebody's face, okay, which happens and is not unusual. Avoiding big groups is a possibility. I would say if you are in the 60 to 70, 80-year-old range, you probably shouldn't be going on a cruise, okay? I'm sure they're cheap and you can probably get like a 2-week cruise for $100. But you could end up with a 14 to 28-day paid vacation if you go on a cruise right now. Just look at what's happened. So probably none of that. A lot of our meetings are actually being canceled all across the world, from infectious disease to cardiology to rheumatology. And I think more importantly, please don't use a mask. So I don't see anybody in this room that's using a mask, which is fantastic. We don't have any in Augusta anyways, but actually it's a good thing. Leave the mask for the people that are sick or the healthcare workers. And you certainly shouldn't be buying those N95s that are going for a couple of $100, on Amazon. You don't need the mask. The masks go on people that are sick, right? The masks go on the healthcare workers to prevent them. Wearing a mask, especially if you have, like I do, I have a beard. If I have growth, it doesn't work because it leaks, all right? So as a matter of fact, if I go see a patient, I'm gonna have to either shave or use one of the other forms, which is called a PAPR. It's kind of like what you see on TV, when everybody else is doing it, covers your entire, but don't use a mask. You're actually just increasing that. Last but not least, so this is hand hygiene, and this is what we need to pay attention to. When you wash your hands, areas less likely to be missed, you can see, and then areas more likely to be missed. So besides washing your hands this way, in between your hands is very, very important. Anterior and posterior at the same time. So it's important to know, if we do wash our hands, wash them correctly and wash them adequately. So this is something that was actually picked up. We actually picked this up from the old SARS, and I've had this for almost 20 years. We are sorry, no shaking hands today. A smile and a nod, it's supposed to be a nod, will do, okay? The same thing holds true. A smile and a nod, or a smile will do. Just a little bit real quick, what we're trying to do here is keep calm. And so the public perception of outbreaks and plagues, which sounds like a really bad and nasty name, we know that there's a fear, there's actually an ancestral fear of unknown things. This actually comes from a lecture I gave the psychologist a couple of years ago. Intrinsic is something else that we don't know about, especially when you hear of a pandemic, an epidemic, a plague, and then primal, obviously, going way, way back in our DNA. So we go from a fear to a panic, which is kind of where we're at right now. Every time, somebody speaks in the media, we hype that panic up, and some people have actually hit hysteria, right, at this point in time. Why do I know that? Because there's no antiseptic or toilet paper now at Publix. That I would call hysteria, okay? if you're going out and buying everybody's toilet paper. So my neighbor actually got 100 boxes of water delivered to his house. I'm not going to say which one, but he got 100 boxes of water. Water's okay. The coronavirus is not going to affect our water supply. That I can guarantee you, okay? So you may have to drink tap water, but that's okay. That's actually pretty good. It'll prevent you from getting rotten teeth. So it's got fluoride. So the fear of death and isolation becomes important. And then at the end, this apocalyptic concern that the world is ending, that's not going to happen with this. So I'm making a little fun of it. It is a serious condition. We do have to be concerned about it. We do have to pay attention. We do have to pay attention. There's some media here, but media effect and public reaction is very, very close. I think the media here has actually done a great job here in Augusta, because I've been speaking to them now for about a month, but we are a media-soaked society, and more than anything, it's Twitter, it's Facebook, it's all of those that are out there. Please don't pay attention to all the stuff that's out there on Twitter and Facebook. 90% of it is incorrect or inappropriate information. Perhaps listen to some of us, listen to some of the local media when they interview us to go through this, because the public opinion is carried away by what I call the feeble-minded media hype, and that's Twitter and Facebook and those where people are putting out all sorts of weird things. If you've seen, you're supposed to be many different home remedies for coronavirus, right? That's crazy. It's going to kill people when we see that. So even Dr. Oz has gotten very odd, drinking elderberry 5 times a day to prevent coronavirus. I'm not sure where that's what I'm saying. So even some of the people, so you have to be careful with what we do. Lessons learned from SARS and Ebola. Need for designated, prepared, trained, and equipped hospitals. We are there, definitely with all of the above. The leadership, as you well know, especially the resupply, the resupply and the staffing is something that we are on a daily basis in these meetings. The need for culturally appropriate public information is one of the things we're doing now that can be acted on. Staffing, respite, quarantine, and self-care is something that we are discussing and we are pushing. Need for limited time at risk, so rotating teams. There are different people. Most of these individuals that we see are actually coming through the ED. The emergency room has done a phenomenal job at handling a lot of these individuals that we come through, and the need for published contingency operations, which we all have. As President Keel said, we are definitely over-prepared, and we want to maintain this over-preparedness to make sure that we don't get fooled into some kind of submission that we're not ready for. But rest assured, for those folks that are listening to me or listening to us, that we are prepared. We have gone through these contingencies probably since Ebola. We started generating these, and now more recently with the SARS, adapting to the SARS, and we'll be ready for whatever happens. So finally, things to do if you suspect somebody is identify a patient. If you identify a patient, isolate the patient first for those healthcare workers, and inform contact infection prevention, infection control. We will take care of all of this. Infection prevention will take care of it. Actually, Dr. Kuhl or myself or somebody from infection prevention will then guide you through what you need to do with the suspected person under investigation or that suspected patient. Isolating the patient becomes important, and making sure that you're using the personal protection that we all recommend, whether it's the gowns, the gloves, the N95, and then once informed, you can see there are certain phone numbers or extensions that can be. So we are ready. These are the phone numbers that are important. As President Keel said, go on the website, gives you all the information. Jaguar gives you the information. We have a lot of information out there to keep everybody up to date, and that's continually updated on a daily, if not several times a day basis. And I think with that one, I will end it, and I thank you very much, and we're going to take questions. Thank you.
Clapping is still okay.
Thank you, Dr. Vasquez. So we're going to take questions from the audience and also online. The information to submit a question online is up there. Those in the audience, if you're going to ask a question, please do use one of the microphones so that we can respond to that. Sure. Who would like to go first? Go ahead. Go ahead.
Matt Alcadora, first-year GI fellow. Two questions. One, being part of a GME program, is the GME going to send any direction to our program and other specialty or subspecialty programs? You mentioned about the quarantine isolation if one of us gets exposed to a PUI or a confirmed case. We have limited vacation and sick days, just logistically speaking, as far as a separate 2-week vacation isolation.
Yeah, so just to make sure everybody understands the question, if I understood it correctly, the question is, so what about people in learning programs and that are residents and fellows? How will we communicate with you about a case that you were involved with? And I'll take that one step further, as more importantly, are we going to have you involved in cases of known COVID-19 or even suspected COVID-19? Our approach right now is to not involve any learners in the evaluation and care of potential COVID-19 cases, and that is for multiple reasons. One is to minimize the risk to our learners, but two is because we want to minimize the number of people that come into contact with that patient. So we're asking for attending physicians to be the person to go into the room and evaluate that patient, rather than having a medical student, a resident, a fellow, and the attending go in to evaluate that patient. In the event that somebody does become exposed, our infection prevention department, in conjunction with employee health, will reach out to you and certainly notify you of that. And we're working on what our policies look like in our response to that in the event that we do have someone that is exposed.
Just a quick question number two. A couple of studies published in Gastroenterology from China, February 26th, and one in JAMA, March 4th, showed that the virus is also shedding in stool. And, being in gastroenterology, we do a lot of colonoscopies, and there's also a lot of, interaction with stool on the floor with nurses and all that. So any direction as to extra control, infection control for that? Because it's still unknown, obviously, how long after any PUI or confirmed case will continue to shed the virus in the stool. Like you said, though, it is easily...
And you just answered the question yourself, right? So this is easily killed by hand washing. So whether or not there are additional precautions, there's no guidance from the CDC on that yet. Again, since it's not being expelled, it really is just the normal precautions with that right now. That may change. And I don't know, Dr. Vasquez, if you want to comment on that. But again, the same thing is, use the normal precautions and then make sure that you're washing your hands. Do you want to comment?
So those studies, is this on? The studies that were done were PCR assays, and the problem with PCR assays is that doesn't necessarily mean there's live virus in the GI tract or the stool, so we still don't know. It's kind of the reason we don't do PCR assays for C. diff after the patient's been treated. We don't know what the infectivity of the stool is. We just know that they can. The time of infectivity is still a question, right? So that's of concern. So we don't know at this point, but using the same precautions is probably the most important part. But we don't know what the infectivity is of stool after a while.
And that's a great point, actually. The analogy to C. diff is a great one because we're over-testing for C. diff, and the test is so sensitive that we're diagnosing C. diff in patients that do not have active disease, and there's probably the same phenomenon occurring with this. Just because we can isolate it there doesn't mean it's necessarily as infective or that it's a disease state. Yes, sir.
Thank you, Dr. Cole and Dr. Vasquez. And you mentioned, Dr. Cole, very correctly about the vaccines. As you know, I have been working on the mathematical modeling here. So one question I received after the AI model, artificial intelligence model that we are developing, the question it came to me from Washington was, even if the vaccine is available, can we model to understand how much time it will take to completely vaccinate entire US? So one of the things, just today morning I reported back to the Washington based on the complex mathematical models by considering all the hospitals within US. Even if vaccine is available, it could take 2 years, 2 to 2.5 years only in US to vaccinate. And to produce itself, it might take 7 billion vaccine kits to take it long, so many years. So I think the hand washing, those things, that we also compared with hand washing and prevention versus the time taken for the vaccinate everyone, and the vaccination going to take a long time.
Yeah.
Based on
So
mathematical modeling, at least.
Yeah, thank you for that, and love the work that you're doing with the development of the app for looking at the risk. I think that's fantastic work. The second part of your question about the vaccine, I think it's too early to know. We certainly have plans in place to mass vaccinate. We did a lot of pandemic influenza planning years ago with public health. The state's done a lot of mass vaccination planning. And so I'm confident that we can vaccinate large numbers of people very quickly. We just don't know when the vaccine will become available, and then what the supply is going to be and what the strategy will be. So it's too early to really comment about how long it will take to do that or how effective it'll be. Miller?
So my question, is it on?
Yeah, it's on.
My question is perhaps for Dr. Keel or Ms. Kiefer, which is, how is the university going to address the situation of people who perhaps should be self-quarantined for 2 weeks, but I don't have enough sick leave. I can't afford to use up my sick leave for this. I need my sick leave for when my babies get sick. I hear those comments just normally run of the mill. So how is the university going to address that with this?
Thank you, Noah. That is a great question. I'm also going to look to Susan Norton is here. I'm going to ask if you're prepared. I may have you comment on that as well. That is an issue that we're having to grapple with and deal with right now. I'll have her comment on that. With regard to students, and we did have this conversation on a phone call with the system office yesterday. If students are going spring break to one of the level 3 countries, we will force them to self-quarantine. There's no question about that. Now, we're also going to do it in such a way that the student, him or herself, is not penalized from an educational point of view. That doesn't answer the staff question. I'll ask Susan to comment on that. But we're going to do everything we can to make sure that regardless of how we move forward, to the best of our ability, that students are not going to be penalized in any way from an educational point of view. And we're already working now with our faculty to try to find some creative ways to address that. Well, with regard to the staff, I'll ask Susan to comment.
Certainly, we want to be sensitive to our staff who may be experiencing illness from this. Sick leave is available to them. As you mentioned, we have both sick and annual leave available to staff. For our 9-month faculty, our academic year faculty, they have sick leave available to them as well, but not annual leave. Depending on the employee in question, they may also have unscheduled holiday time that would be available to them. And it's possible if they are a non-exempt employee and they have worked some overtime, then they would have compensatory time. And so they can draw from those different leave buckets to cover any absence. In addition to the leave that is available to an individual to cover their absence, this is specific to the university. We can offer telework if their job is conducive to that. And this would be something that the manager should evaluate. Does the individual hold a position that can be performed from home? The same would hold true in the health system. The health system does not have compensatory time, and the health system does not break its leave up into the various buckets that I just mentioned. The health system has what is referred to as paid time off, and so the individual would draw from that leave bank as well. Certainly we can work with people on an individual basis, and the telework may be an option to address what you just mentioned.
And we are going to be asking managers on both the health system and the university side of the house to work with us all on dealing with this particular situation. If you as a manager have a question about one of your employees that for whatever reason either needs to be quarantined or isolated, please get with HR and we'll work with you to try to find a way to make that possible.
In addition to telework, it may be that a flexible schedule could come into play as well. And so now is the time that we want to be flexible with our faculty and staff.
And so please let us know the particulars so we can work with you to accomplish that.
And again, we are working with the Board of Regents and with University System of Georgia on the university side of the house. We're not experiencing issues here that are unique to Augustus, that is across the entire state. And we'll be working with them to try to make sure we can manage this as well.
I have to say that I don't think that's an adequate answer, because I think that there are people who don't have, I mean, I have tons of sick leave, okay? I'm not talking for myself. I'm talking for people who they have just worked here a year or two. They don't have a storage of sick leave. And I think that should a situation occur that people have to self-quarantine, that the university should be willing to grant them extra sick leave time for the safety of everyone.
We can certainly take that to the university system because that would be a system-wide decision in terms of university employees. The health system has more flexibility, and that
Within the health system, we have had specific cases that didn't have to do with coronavirus, but maybe a devastating, a recent employee recently hired without a lot of PTO may have had an unfortunate event in their lives, and we have had a committee that's formed that looks at by exception so that we can hold our employees harmless. But we have to be very careful in balancing those messages with, I just don't feel good and I'd rather stay home with my baby and I'm just not going to work for a couple of weeks. And so as long as we have the integrity of the process in place, that we can ensure that people that need to be at home stay at home, that keeps our patients safe. And for any of you who have heard me speak this year, accountability is the word. It's accountable to yourself, accountable to your teammates, so that we are accountable to our patients. And we have ways of looking at specific examples. We just don't want to broadly say, you're going to get 2 weeks free. That's not a message that we can do given our current financial state. So I will say that if that comes up, that should be escalated through the vice president and will come to my office, and we will have the committee to look at that the same way that we did when a tragedy hit one of our direct caregivers who had only worked here 2 months.
We have
If you're
multiple.
aware of situations, please bring them to our attention so we can address them on a one-on-one basis. As Ms. Kiefer alluded to, we are willing to work with people. We just need to know the particulars so that we can. Thank you.
Miller, online question?
Online question. We actually have multiple, so I'm going to paraphrase multiple questions into one to save time. And the question is, faculty travel conferences, are there any plans to limit any of that at this time?
There's no message yet from the University System of Georgia office concerning that. And Dr. Keel?
As of right now, there are no mandates about faculty travel, both either domestic or international, with the exception of we're following CDC recommendations. And the city recommendations, and you can help me with this, that there are those countries that are level 3, and I think there are 5 of them: Italy, China, Korea, Iran, and Japan, I think it is. At level 3, then those are required to self-quarantine. Well, as it is right now, we have no restrictions on travel, no limitations on travel. Use your better judgment.
And another question we have online is, are there plans for the SARS-CoV-2 virus to be included on the respiratory pathogen panel?
So that's really a question about testing. We are aggressively pursuing the ability to test for this specific virus. It won't be included on that panel. It will be a restricted test that requires approval so that we make sure that we are not over-testing, but as the supply and the capability develops, we'll be able to lower that threshold for testing, again, as soon as as the situation warrants. Next.
Thank you for having this panel today. I think it's been informative. I am coming from the academic side of the house. I work with the PA program. We have students who we take into Georgia War. We take them into the hospital. I was in the hospital this morning with some students, and that is a concern. So our students taking them into Georgia War, a nursing home. I do understand that Georgia War sent out an email this morning saying that they would scan temperature of students coming in. But what is the response from administration, meaning should we continue to take students into nursing home type situations or even into the hospital?
So we're looking at the situation and the visitor issues very closely and trying to consider the impact of those. We certainly want to maintain our mission and minimize disruption to student learning, but we also need to keep our patients safe. And those environments that are higher risk, I think we will probably look at when it's appropriate for us to do that. Right now, we don't have any community transmission here. The risk remains low. At some point, that may change, and we will follow that very closely, and we're working very closely with Georgia War Veterans Nursing Home to make sure that we're providing any information and resources and recommendations to make sure that we keep our patients safe. Other questions in person? Dr. Robinson?
Yeah, to follow up on the Georgia War, I go over to the Augusta State Medical Prison, and a lot of our departments provide clinic services over there and operating room services for that matter. The Augusta State Medical Prison is a combination of a nursing home as well as a hospital. It's also secured. And actually, I was flabbergasted, going through the security gate at the Augusta State Medical Prison is really an exercise in mixing fomites around for everyone. There is whenever you take anything off, it just goes into the general pool and you get it back. It has gloves on, nothing is done sterile, nothing is done. So I think it is important for us because it's a part of our mission. We are indeed in charge of correctional health. And how would it look if the spread of coronavirus was in Augusta, was from the Augusta State Medical Prison? So I think it is something that we have to lead on, it's something we have to preempt, and the fact that there's no local cases yet is something that has to be dealt with in detail right now.
So we are working with correctional health personnel to make sure that they are following the CDC guidelines as it exists in terms of correctional health. They are screening visitors that are coming into the facility for any illness to not allow them to enter the facility if they're ill. And they are following currently all of the CDC guidance. But if you have suggestions of maybe where there's room for improvement there, please let me know and we'll put you in touch with the right people to make sure that we can do that. Dr. Hilton.
So thank you for doing this. It's very educational. My question kind of follows up what President Kill said about the students who are choosing to go to these level 3 areas for spring break. So there are hundreds of academic institutions who have already enforced a travel ban. A lot of us, myself included, have canceled our personal travel, even when it is professionally not savvy to do so. What are you going to do for the providers who seem to ignore common sense and are still going to these conferences in hot zones and then want to come back and see my patients or all of our patients? Because that's patients first, right? So we've got providers flying to these areas, and some of them, you know the ones I'm talking about, they're not going to self-quarantine. They're invincible. What is the institution going to do to protect our patients?
Sure. So again, the university system of Georgia has not put out guidance yet, but that does not prevent faculty from using good common sense. Traveling to a high-risk area right now is inappropriate, and faculty, staff, residents, whoever they are that return from a high-risk area may be subject to a 14-day quarantine. If you have risk to our patients, we put our patients' safety first and our students first, as Dr. Keel said, and if someone has risk, we will restrict them from access to being with our students and our patients for the 14-day quarantine period if indicated. Again, there's not a ban on common sense here, and not a ban on using good judgment. And we certainly ask all of our faculty and staff to do that. I think we're over time, but Miller, do you have one more question or no?
There was a question regarding what types of disinfectants would be effective for use.
This virus is easily killed by soap and water, household bleach diluted 1 to 50, and then there are numerous products out there that are labeled as effective against SARS-CoV-1. That's the virus that occurred 2002 to 2004 timeframe. You'll see that label on the back. It'll say SARS-CoV. For example, Lysol works very well. Not to endorse the brand, but Lysol is labeled as effective against that. Clorox wipes. Again, most things kill this very easily, including sunlight, and so going outdoors is a great thing. Thank you, everyone, for being here. Joe has an additional question. If you have submitted a question on the live stream via email or otherwise, we will make sure we follow up with you to make sure we answer those questions. We'll also put them in our FAQs, perhaps. So thank you to everyone for being here. I hope this has been useful for you. Have a good day. Remember, stay calm and wash your hands.